Facebook. Alrighty. Looks like I'm back on.
All good.
Thank you, sir. I'll start the webinar. You guys ready?
Yep.
Okay. Well, hello, this is Jim Morgan. I am with Life's CoPilot, and we have an outstanding panel today. May is Mental Health Month, and so we have a bunch of experts on mental health care and what's going on here to help us navigate this whole process. So I'm looking forward to this one, getting some information out here. So first of all, let me just kind of introduce our guests. And Heather, would you like to get started? Tell us who you are, who your company is, and the scope of services. So you take your time to explain this because, you know, we'll do this for everybody going across the board here. So go ahead.
Okay, so I'm Heather Niles. I am a clinical liaison for Assurance Health System. We are a geriatric inpatient psych hospital that we do short-term hospitalizations. We specialize in treating patients with dementia, major depression, anxiety, psychosis, sexually acting out. And in that, you know, there's like physical aggression, verbal aggression, having hallucinations, delusions. So we take patients who are in like crisis mode. So generally they have to have criteria having these behaviors within a 72-hour window. And then we will assess them and bring them in for 10 to 14 days is an average stay. And generally our patients are 65 and older, but we can take some younger that are in their 50s if they meet the geriatric criteria.
Okay, well, very good. Well, thank you. So Tina, you're next on my top of my screen here. So let's have you introduce yourself and who you are and all the things that you guys do.
Okay, well, I'm Tina Baxter with Baxter Professional Services. I am a gerontological nurse practitioner and a legal nurse consultant, and I work with individuals and families on managing their stress through Baxter Professional Services. And I have some interesting things for nurses coming up because it is Nurses Week still, yet today. And so because of the incidence and increase in suicide in nurses, I have an event for nurses for spiritual renewal. So that's for anybody that would like to come. I have that open and available to them. And I'd be happy to share that link. And I really like what Assurance Health does because for older adults, having been in long-term care for a long time as well, I know what it's like to have that phone call that someone's acting out in your facility because my specialty is geriatrics and my subspecialty is geropsych. I'm also working with adult and child health in Indianapolis as well.
Well, thank you. Michael, introduce yourself and your company and tell me what all you guys do.
Definitely. Hey, everybody. I'm Michael, chant with Greenhouse Mental Health Care. Now we've kind of had a merger in the last couple of weeks with another company. We're 360 Care now, so that's kind of all taking place within the last week or two. So basically, what Greenhouse is we are a mental health care provider. We go into the long-term care, assisted livings, independent livings, skilled rehab centers, and we perform one-on-one talk therapy with our licensed clinical social workers. And then we also have psych nurse practitioners that go in there and do the med management that they need at these facilities. We also do neuropsych evaluations. We have HSPPs on staff that can go in and perform those. So I'm one of the account managers for our company. So my role is to kind of get new accounts and whatnot, and just kind of establish that relationship with the nursing homes and the long-term care facilities, so we can kind of have that connection. And yeah, that's kind of who we are and what we do.
Okay, very good. So, congratulations on your new company, I guess.
Yeah, it's been a transition, so it's been an exciting time. So,
Kimball, please tell us who you are and what you do and what your whole entity does. So
Thanks, Jim. This is the great thing to be on this program because it gets me, I learn about my business by meeting folks and getting caught up with everybody else. So thank you for the invitation. I'm Kimball Richardson. I'm the manager of business development for Community Health Network in behavioral health specifically. So I'm a licensed mental health counselor as well. And Community Health Network is one of the what do we have? 4 or 5 large healthcare organizations in the central Indiana area. We are one of them. We have 9 acute care hospitals, over 200 sites of outpatient care. And our behavioral health product line, as we call it, is I think the largest in the state. That said, we need partners and we need friends all over the place because we have such a high need for inpatient and ambulatory care for anywhere from infants to over 100. So,
oh my.
Yep.
Well, we're going to go. This is it's May as Mental Health Month. We are dealing with an explosion of issues in that, from what I understand. So Tina, I just wanted to piggyback back on something you said because I had not heard about this, about the nurses having a major spike in suicide. Or
Yes, one study said that the average nurse thinks of suicide double the amount of the average person, and that's for male and female, so male and female nurses. And in the last couple weeks, I've covered 2 nurses that have completed suicide out of California. Actually, they left their shift and went and completed suicide. So this is something that's becoming more prevalent. A lot of nurses are striking for mental health benefits. They're saying, hey, we need something to help us because of everything that's going on with the pandemic.
so you think it's pandemic related, just the extra stress of that, or is it?
I think it's that, and covered with the shortage of staffing, with the nursing shortage that's going on, it's causing a backlog of issues. And then you're working in an environment where you may not know your coworker because it may be a travel nurse. So there's a lot of factors that go into this, and we're seeing this more and more. And I've also just left a assisted living, and they're having similar issues in their staffing and their turnover rate and the mental health needs of their employees as well.
So it sounds like to me that they're similar circumstances that our military had gone through when we downsized our military tremendously, to where you had a very small number of people, but then they just kept sending them back, over and over and over in deployment. Kimball, you want to say something? I can tell.
That's a very astute comparison. And I'll echo what Tina just said. It's anecdotal from my network, but I'm sure you can find it's all over the place. That and I'll just say for my own my very own house, my wife's in intensive care unit. This is her 30th year of bedside practice, and yeah, there's lots of travel nurses, and although they're nice and they're qualified, when you're working in acute care, really in any care, but especially acute care, you have to be able to trust your partners, your coworkers, and sometimes trust takes a minute to build over time. And when you've got folks that are new or sometimes changing, it can be somewhat challenging. So I think she's right on target.
Well, beyond the trust is also just the camaraderie, that somebody that's in a shared experience that and you've known long enough to trust and vent if you need to or what have you. So yeah, I can see that. Yeah.
Well, the other thing is that we didn't talk about was the fact that a lot of healthcare workers had COVID themselves, and we've seen a rise in those that have died for COVID-related issues. And so that's the other layer that you have to think about, is that you may have a coworker that you work with but are no longer there because they've gotten COVID, or they've had a family member that's gotten COVID and there's been a death. So there's that added component as well.
Interesting. Well, that was not, I wasn't going to go there, but that was a new thing that I hadn't heard about. And I'm glad that we had a chance to discuss it because, there's a very good chance there's nurses watching this. So, so basically we're talking about like with the older adult situation. I was sitting there doing a little research, and I saw that they project that 20% of people age 55 and older experience some sort of mental health concern. What are you, I mean, are you guys seeing an increase in this? Is this something that, I don't know if we want to tie it to the COVID treatments and all that kind of stuff as well. It could be, but what's going on that you guys are seeing out there in the public? I don't care who wants to answer first. Anyone see anything?
Yeah, for us in the long-term care and the assisted living, it was just, it's picked up just because of, them being isolated with COVID and whatnot. They couldn't do anything for 2 years. They couldn't have family or friends or anybody come visit them. So us being in that position to kind of help aid that and be there for them, just for that talk therapy piece. I feel like, it's been big benefit for them. So we've seen a spike, obviously, on our end in those settings. So
Let me just throw a number out at you, Jim. And hello, puppy dog wants to be heard.
Yeah, my dog wants to help. Yeah.
This is, I'm going to give you a number, and the number is 5,000. Okay. And this is the number that we received at Community Health Network for requests for new outpatient appointments. 5,000 in 1 month. Okay, we're one organization, we're one service line, and I'm talking 1 month's time, 5,000. And prior to that, that's the highest we've ever had in the history of having behavioral health at Community Health Network. And we've been doing behavioral health since, the late 60s as a program. So it is overwhelming, and I want to give a shout out to all the providers who are really trying to be creative and find ways to care for people. So there's a big need.
Well, Heather and I were just talking about this right before everybody got on. And one of the things that I personally have experienced anecdotally dealing with a family member, but from what I understand is endemic, is the fact there's just a shortage of beds. There's a shortage of available space, especially for the senior, the geriatric patient. I know my family member got crossways with, in fact, I think Kimball talked to you about it, but they got crossways with one of his counselors and wanted a new one, and trying to find a new place to fit in with Medicare or something. It was better. We were forced to make them figure out how to get the two of them back on track, which worked, but that was where are we on that 5,000 people? I don't know if you guys have anywhere near the capacity to handle 5,000 new people, but in a month. But
well, we can, and that's why we have to have partners.
Mm-hmm.
We have to know people in our community that we trust and that may have some capacity. I literally, everybody's having challenges with capacity right now. So the good thing is that people are asking for help. We do want that. That's the good thing. The challenge is providing it.
I was just going to say, at Adult and Child, we are inundated with new client appointments as well, and that's one of the challenges. I mean, I was looking for an appointment for a client today, and I'm booked out clear to July already, and that's for new patients. So that's the challenge that we face, because when they come from assurance or come from community and we see them in outpatient, we now have to find a therapist to get them to engage with, and then get a provider to prescribe their medications. And so we're looking at creative ways to kind of bridge some of those gaps.
And I have found, because my clinical liaison position is where I go into nursing homes, hospitals, home health, and just do that marketing liaison piece. And then I'm also that first person they call when they need to make a referral. And when I go into buildings, I'm finding a lot of time where, they're like, well, I'm out here in the boondocks, and we don't have therapists that come in. Like, I've got a patient or a resident may not need inpatient hospitalization, but they could really use some talk therapy. And that's been like a huge thing where, like, I've been trying to reach out to different resources to provide them with a resource that could provide that outpatient piece of it, because we deal with the inpatient hospitalization and psych management, and then rounding providers who consults with Dr. Snyder, they can do that medication piece in-house, but it's that therapy piece that I feel like really is needed.
Yeah, Heather, we work pretty closely with rounding providers in the Fort Wayne market. So we're in a lot of their similar buildings for talk therapy, but kind of to echo what you said, in the rural areas, we've kind of hit that staffing shortage too for social workers and that talk therapy piece. So it's been a struggle for us as well to kind of get in there and provide these services with kind of the staffing issues as well. So.
And going back to what we saw during COVID, what I saw a lot of is families keeping their loved ones at home longer, and where they normally would have put them in assisted living, they're going straight from home to needing psych help because all of a sudden their loved one is combative with family, doesn't recognize family, is paranoid, is exit seeking. And so all of a sudden they're in crisis and they're like, we need help. And so then they're calling us, and we can do home assessments. So, we're bringing patients from home to us and then helping to find that memory care placement. Whereas if it had been before COVID, they might have put their loved one in assisted living, giving them a chance for the, milder levels of dementia to be able to have more independence and function before going to that memory care.
There are some of the common conditions that we're experiencing are anxiety, severe cognitive impairment, mood disorders, depression, bipolar disorder. So, I mean, across the seniors, and then they were talking about the suicide we were talking about earlier. I guess they say older men have the highest rating, like 85 and up was one of the higher ones that are out there. Is this, I mean, I don't think this is new. I think the article I'm reading was from the CDC, and normally their data is 2 years old. So, so I'm assuming this is data before COVID even hit. So, so what is this a normal situation, or are we seeing it more because we're seeing the graying of America? There's so many more, 10,000 people a day are turning 70 type thing, or so are we seeing the same percentages, but just more numbers? I guess you guys are the ones that are there on the front line.
Well, let me throw something out at you, Jim, that my colleagues will already know. That what do you think is the number one, according to research, the number one reason that people can stay resilient even into older age? Do you know?
I would say connectivity.
That's what I say too.
Right on the button is social support. And there are other things, of course, that go along with that, but that tends to be, especially for people 65 and older, social support. And that doesn't have to mean, lots of friends, but even one person that you can talk to or relate to. And so being isolated, being withdrawn, not being used to, this is the generation of, you don't talk about your feelings openly. It's a little unusual. It's not until, and please guys, it's not, please chime in, but I just gave a presentation 2 weeks ago. The whole audience was law enforcement professionals. And a lot of them were in their 20s and 30s, and they were talking about mental health all over the place. I was like, guys, I've never, wait a minute. I wasn't ready for it. I was ready for, hey, I'm going to have to really work to get a conversation going. It wasn't like that. But so it's generational too. Thank you.
So our seniors right now are the ones that are probably the strongest in that reserved area. So at this point, what again, you say that, you know, I don't know if we're changing that, if the numbers have increased because we have increased numbers of seniors, or if it's because, you know, if the percentages are staying the same, or if it's, or if the percentages are increasing. I do know that, you know, again, anecdotally, I've been watching family members that are in the senior family members that have been so bombarded. They've been locked down because of COVID. Then I think they spend almost every waking hour watching some news channel or another. And so they're constantly getting that poured into their head, you know? So, I mean, I can actually for me, I can pretty much tell what channel someone watches within 3 minutes of walking in the room with them, because it tells me kind of where their heads are, you know. But I think that's got to be part of it. I mean, if all you're hearing all day long is, you know, whoever's version of doom and gloom. So what, how do we, go ahead.
No, I think you're exactly right on that. And if you only have your own, you know, if you don't have a counter opinion, you only have one opinion coming at you all day, and you don't have anyone to challenge that or to present other options, others' opinion, you sometimes you get focused on that one way of thinking, and sometimes that's not helpful.
You know, so one of the, go ahead.
I was gonna say, I often tell my clients, I say, all right, you can watch the weather, you can watch the traffic, and you can watch the story about dogs and puppies all day long, but after that, turn it off. Because all it's going to do is get you back into that negative mind space. And I said, the world can be a scary place, but it's also a beautiful place. And we have to hold on to that.
Yeah, and I don't care which network it is or which slant they have. Their job is to sell more people to watch, and they do that by trying to do it through, you know, scare and what have you else. So it's kind of like I'm always talking them down, going, you know, 99% of this is BS. Okay, so now let's go back to the other, you know, and I don't care which one they're watching. It doesn't matter, you know, so, you know. So what, some of the behavioral risk factors, what kind of things can we be doing? You know, is it, you know, they're talking about different communities, different states, different cities have different things. Is there something that we can be doing, that we can be trying to do to help, you know, keep our people out of these circumstances? What can we be doing to as a community, as a family, as a network? What can we be doing?
This is something I just participated in yesterday. I thought it was a brilliant idea. It'll take a minute to take a hold, and it will have to accommodate people who can't ambulate very well. But there's a local park system. I guess we can say where it is, since we're all central Indiana, but Fishers, Indiana. Their health department is partnering with their parks department. They created a series called Walk About Health, where the different parks that they have will have different speakers about a healthcare topic. Yesterday, it happened to be about mental health. And so we went to, and since I was the presenter, I got to select the park, and I'd not been to it before, but it sounded like it would be sort of quiet and confidential. It was the Ritchie Woods Nature Preserve, right? I'd never been there before. It was absolutely beautiful. It was quiet. It was, you know, confidential for people to walk around. So I gave just a little didactic presentation, and then other people talked, and we just talked about health as we were walking. So we were walking, doing something healthy, and talking about a mental health topic, and offering resources.
Well,
so
excellent.
That's one way.
That's excellent. We have somebody who would like to ask a question. Kim, I just gave you permission to talk on the chart here. So.
Okay, I don't see myself. Is there a way to?
I don't know. You've got an opportunity to talk though. So.
Okay, but you can hear me. Okay.
Yes, we can.
Okay. I joined this call because I I've kind of been led by the Lord to come up with a company that puts together everything for seniors to help them age well. And what I'm finding is that there's pieces of the whole puzzle, from the legal to the medical to the care to everything. But it appears to me that most seniors are, in my talks with care managers, the typical thing that happens is they're living independently, whether in their home or like I do. I live in an independent apartment, a senior apartment. But when there's a catastrophic event, they break their hip, they get a bad diagnosis, they go into mental health crisis, something like that. When there's a catastrophic event, that's when Medicare and everybody else, their Medicare Advantage plan, that's when everybody gets mobilized. They end up in the hospital. They might have another 30 days after they get fixed for vocational rehab, but generally they can't go back to their independent living situation. So they're forced to go to assisted living at that point. So I think what I'm trying to say is that I'm kind of being led that I want to put together a company, and I found your website, the Life's CoPilot, by doing a little digging, right? So that's why I'm on this call, and I don't mean to monopolize anything, but I would like to do something where when a senior still has their faculties, both physical and mental, that I can present to them a comprehensive plan that goes beyond being a financial planner, goes beyond being a lawyer that does their estate plan, but a comprehensive plan to help them age well, with the intent that if they're planning, if they're proactive instead of reactive, because that's what I believe the system is. It's reactive. If they're proactive, then it should allow them to have more days, weeks, if not years of independent living, and give the whole system, a better chance to catch up and to do what they need to do during those reactive periods. So am I way off base?
No, you're not. I think that, in fact, you found Life's CoPilot. That's what it's designed to start doing as far as that goes. That's why we have these, and I'm glad you found us. I would love to get a chance to talk to you further. Why don't you, on that Life's CoPilot, there's a place where it says, contact us, and that goes to one of our co-pilots, which, by the way, at this particular point is me. So then we can get together and visit on this, because I'd love to hear more about what you have in mind and see about putting the connections together here. So that sound good to you?
Yeah, it does.
All right, great. Well, let's reach out to me and let's get together.
Okay.
Anybody else have anything you want to say on this, or?
I was just going to say this is an excellent opportunity to work with a nurse care manager to help you do that. There are some programs out there that, like the adult daycares, sometimes have a program that will help do that, managing everything like medical appointments and meal delivery. They can kind of help coordinate all that. So that sounds like what you're looking for, someone to help coordinate that, but also to help seniors to think for the future. Because one of the problems that I face with engaging older adults is sometimes they don't want to talk about the future. It's like I'll wait till it happens to deal with it then. I had that similar situation with my own mother, working with my dad, and it unfortunately became an emergency situation to get everything in order, but we were able to do that. And so having seniors that want to be proactive is very important. So I think that'd be great for you guys to work on something collaboratively, and I'd be happy to assist in any way that I could.
Yeah, and just have like resources like home health companies, because there's some that focus on the non-medical, like helping with light housekeeping, just doing errands, that kind of thing. laundry. And then there's also then that medical side that the nursing could come in if they needed it with medication management and other assistance.
One of the things it does, Kim, there's home health, there's home care, there's all these different resources that are out there that really can help that person stay and age in place, be it in a independent living or an assisted before they have to go further to a higher skill level. So there's some really good resources out there right now. It's just learning how to access them and work. I would say, other than the fact that we're short on people and beds in the mental health area, I think that is an absolute. But other than that, as far as services and resources and programs, we're not short on those in the senior world. We're short on knowledge they exist and how to access them. And so that's a lot of what Life's CoPilot's all about, is trying to get that word out, trying to get that information out to people. So anyway, that's where that. I also saw, Stephanie contacted us, reached in here, and she's talking about she's with Ritchie Reserve, which is right next to where Kimball was in the park. And they are set up, they're an independent living community in Fishers, and they're set up to be able to bring in those caregivers at different stages so you can stay there. I mean, and there's, they're not unique in that. There's a lot of places that do that. So it is a resource that we just need to make sure that people are aware of and how to access it. So one of the things I was looking at here and trying to figure a couple things out too was, I'll get my brain working here. We have life satisfaction scores. Now, this to me was some good news. It shows that like 95% of people, even in the seniors, have a high level of life satisfaction. So that to me is some good news for this particular story. So that means we are dealing with a huge problem, but we've got a lot of people that have got their things going through. They found their support systems. They found things. So how do we end up helping more people be in that 95%? Anybody have some suggestions here? So you guys are again on the front line, so you're talking to people that are in that situation. I know, again, this is anecdotal, but dealing with a family member that fell into a massive depression. And that was my first real experience dealing with that. And it was terrifying. And then it became even more terrifying when we were first starting him on the drugs, the antidepressant drugs. Then we were on a absolute wild ride until those settled in and got going well. It was the scariest thing I've ever experienced. So how do we and the part that I was so frustrated with is during that month or so that he was out there on his this roller coaster ride on the meds, we were getting almost no support. Where do people may not know, first of all, that is a possibility. We didn't know. Okay. They just said it would take about 6 weeks to kick in, and then holy cow, was that an interesting 6 weeks, but total paranoia, running away. It was, thank God he was 87 and it's slowing down, so, but I don't think people realize what kind of a ride they can get into, and then what resources to go find, solutions to that ride. So that's why I've got you guys here. Let me see if I can get some help for the person that might stumble into that roller coaster. Anybody? Tina, I'll pick on you. So.
Okay, I was going to say often the first stop will be your primary care. That's usually where people go. They call their primary care physician and to try to get a referral or something. Certainly, Heather's group, depending on where you're located, could probably do an in-house, in-home assessment. But it may be if they're at the point of the running away and not safe, they may need inpatient care and meet the criteria for that, and then be able to transition them back to outpatient would be the ultimate goal. But yeah, it could take 6 weeks for the meds to kick in, and you have to understand also with some of those medications in patients who have dementia, they're actually contraindicated. So you need a really skilled clinician to help you with that.
Yeah, because at that point, like if they are exit seeking, if the medications are taking them on a wild ride, then it probably would be a good point to call Assurance Health.
Mhm.
And because we've had it where family members said, hey, we tried our family doctor first, started him on Zyprexa, started him on, this other medication. It's not working. And so, I mean, so we have 2 locations. We have one in Anderson and one in Indianapolis. And Anderson has 20 beds, Indy has 23 beds. And we will transport people probably about 125-mile radius. And we've got our own transport EMTs that will do that. And then if our EMTs are not available, then we'll call and find an EMT that can do that, so that family members don't feel like they have to put their loved one in a car and drive an hour and a half to get to us, and they're worried that the loved one is going to open up the car door. How do we do this? So yeah, so we could definitely help in those types of situations.
In my, again, I'm going, this is anecdotal, this is my family, my circumstance, but it was, and I was totally unprepared for it because it came out of the blue as far as I was concerned, as far as I could tell. But it started off with a attempted suicide. Then that word got out what it was. We thought it was originally an accident, okay, and then we knew what it was. At 9 p.m., we were at a local hospital, not yours, by the way. Yeah, anyway, we were at a local hospital, and the nurse came out, and he had told her what had happened, and she goes, "You don't have to worry about him going anywhere. He'll be here for a while for observation, what have you." At 8 o'clock the next morning, they were telling me to get him picked up because he had to leave. I'm going, "Are you out of your mind?" And they go, "Well, he said he wasn't going to do it again." So I'm like, talk about insanity. I'm going, "Now this is crazy." So then I end up having to, bring him home. They had just put him on those drugs, and oh my God, things got wackier than ever before. Okay. And then that went on then we end up doing 2 stints in the senior psych ward as we're going through this. The second one worked out pretty well because when he came out, he's been just great ever since. But it was, as a family member, as a consumer, as someone trying to deal with this, it was terrifying. It was maddening, and I really couldn't figure out how to get any help. So that was, the people I was going to. In fact, the second time to go into the senior psych ward, when we asked to go back, the psychiatrist said that they would only take him back if we agreed to electric shock therapy. And I'm going, I'm saying, is this one flew over the cuckoo's nest? What's going on here? And then, of course, I'm reading more about it and find out that it's not what I thought it was anymore, at least especially geriatric. But we set a meeting to meet to discuss it. And when we did finally got that meeting, at that point, he said, "I think you can go home if it's assisted living, more social, more, structured." And it's been wonderful. But this is kind of why I'm having this panel. I'm looking for you guys to speak out to those people like me. They're going, "Oh my God, what do we do?" So that's kind of where, because I didn't have you guys, so.
Yeah, and I feel terrible for you, Jim, because you deserve just as much guidance and help and support as the patient. And I don't know if this would have been something that you would have done. They're not specific to seniors, and I don't know one that is, but the National Alliance on Mental Illness, or NAMI, has programs called Family to Family. And what they do is they essentially either teach or pair families with other families who have a family member or friend or whatnot with a mental health issue. And so you don't feel alone. So you understand what resources might be available to you. And there are some classes that you can take that help educate people. Hey, this is what this disorder is, etc. I don't know that they have any specific to seniors, but at least it's something that's available.
Well, I see already from our panel or people who are watching us that Jana has experienced a similar circumstance, and the hospital basically just kind of blew her off. So that's why, again, that's why this is so important to have these panels, so that we can get your voices out there. So, and it doesn't matter if they're watching this here or Seattle, there's someone in your field there, so that they can know who to go look for and who to talk to. If you've got that person, you were just talking about some different resources, Kimball, but I don't know, Heather or Michael or Tina, if you've got a person that just all of a sudden is newly diagnosed or newly having this, because we went from, I never saw a problem to 24 hours later, oh my God, what the heck is going on, type thing. So how do you direct these people through these paths? I mean, what's the suggestions?
Well, I'm going to say from a clinician standpoint, I generally start with a workup, because it could be something medical going on. A simple urinary tract infection can really send someone in a downward spiral. And so we look for those causes. I look at their medications. Are there medications that can contribute to confusion, and are they interacting with each other? Looking at their sodium levels, because if they're on psychotropic medications, oftentimes it affects their sodium. So there's a lot that needs to be done. And I don't know what happened to your loved one in the hospital, but I was hoping that they at least ruled out some of the medical causes that it could be, and really screen them. And that way you'll know, okay, do they need to be in the ICU? I had a gentleman that they sent him when I was working inpatient psych to me, saying that he was psychotic. Well, I know this patient very well. I'm like, this is not psychosis. He's delirious. And so knowing the difference between delirium and dementia and depression takes a trained clinician. And so you'll need to get them to be seen. Well, I sent him back to the ER. He came from another ER to our psych hospital. I said, nope, he needs to go to medical. He ended up in the ICU and almost died. Why? Because he was septic. And everybody said, oh, he's got he's psychotic. I said, this is not psychosis. When he's psychotic, I know what he's like. If I lift his hand up and it flops back on the table like this, I'm like, we're not taking him. He will die here. So you can't die at a psych hospital. It just doesn't happen. We move you to medical as quickly as possible. So you need someone who can understand the differences and the nuances with older adults. And even some primary care physicians and nurse practitioners aren't as trained in the changes in older adults. So they may not see those changes, those subtle changes that we can pick up on because of our training and working with older adults.
So like, and a lot of this situation might trigger in an ER where they've never even seen this person before.
Right.
So they don't know what they're like when they're not in this condition, so that they don't have that.
They don't know what baseline would be, that, hey, this person was walking, talking, going to the grocery store, doing all those things. So when you go into the emergency room, paint that picture for them. Let them know that this person was able to dress themselves, feed themselves, make their own meals, living independently until this happened. So there's something that's happened. I mean, it could be a stroke, it could be anything, we don't know. So they need to work them up medically, and not just say, well, they've got anxiety or, they've got dementia. Well, they were doing really well prior to this. So something's happened that's caused them to have this decline.
Well, we had, in this particular situation, there were a couple changes that happened. Had a medical issue come up, which it was not accustomed to. Then was because of that medical issue was forced to move out of an apartment that he'd been in for 27 years. Okay, so then things just went, off the rail. So and I didn't realize that that move was that big a deal to him. But because to my mind, it wasn't when he just moved downstairs in the same building. But but it was to him. So I think that's a lot. Talking about that, coming from my background, I do with a company called Caring Transitions, and we help people downsize and move, predominantly seniors and what have you. And that's one of the things we're trained. This, by the way, I started doing this after after this circumstance, but that's why I didn't get the training before. But they talk about just that. Heather, you're talking about people moving into an assisted living and what have you. Michael, I think you were talking about the same thing, dealing with that. And when they do, they're one of the things that we have learned through our own training is that move for that senior that's been in their home for 50 years or what have you, and a lot of their familiar stuff, their familiar house, all the memories, and they move to something else, that is more traumatic than a death in the immediate family. It's really a triggering, situation, which is why we try to work really hard to minimize that and do almost like those TV shows where you get the reveal on the other end. We try to do that, put their house back as it was, but in that new space. But that's what we had done to him. We had set him up for failure and had no idea that we were doing so, and then we ended up moving him later, and this time we did it right, and it was a major success story. But little things like that, someone watching this right now may have a family member that I was just counseling a potential client right now that we're working with, and mom is having, she is showing some very irrational signs on this, but I kept trying to tell daughter, hey, this, there's real challenges here. We've got to listen to mom. We've got to figure out how to, minimize this stress process, and, so, for me, it was, I took a beating, okay, and then, then got some training on it. And so I'm doing everything I can to try to help talk other families through it. And that's, again, one reason we're doing this is trying to, because who would have ever known that they were basically setting their family member up for major failure, putting them in this cute new apartment, but they can,
we see that a lot with us, that we try to talk to our facilities. Hey, as you get new arrivals, new people coming in, definitely mention us, because that loss of independence, that loss of freedom is taken from them. They kind of struggle, so we try to start them off on the right foot and at least provide, hey, give them the opportunity to talk to someone if they want to. So that's something huge for us that we try to push.
So that's kind of, so you guys actually do that. So you're kind of like doing preemptive. They're not having this trouble yet. You're trying to make sure that you are getting in front of it. Is that what I just heard?
Yeah, it doesn't always happen at every facility, but we do try to talk to our contacts at the facilities, like the social services directors or the director of nursing, and say, hey, as you get new people coming in, we're here to help start them out, instead of having problems and then having us come in to help kind of fix them. Just let them know, hey, preemptive type situations is better for us sometimes. So
Yeah,
I love hearing that. That could be, that's proactive.
There's definitely a grief factor that comes into that loss of independence, that move. And I think we mentioned before that the older adults, they're not used to talking about their feelings. They're not used to identifying what's going on in that life stage. And just being identify that there is a loss, there is grief, and I think can really open their eyes and go, oh, I'm not alone in how I'm feeling, that other people have experienced this too, coming into a facility or downsizing or not being able to see family as much with COVID or whatever is going on.
I had a client that was a small business owner. He was 90 years old, and he had a physical health setback, which caused him to close his business. and he didn't know what to do with himself the rest of the time, because he's like, I worked every day. You're talking about a generation to where they are they take pride in owning their own home and owning their business and doing those things, and that's their identity. And now we're essentially taking that away from them. So they have to rediscover who they are without that. And this man had to go through a grieving process. I'm like, you're 90. When are you planning on retiring? But he never did. He never made a plan for retirement. And he's like, well, I still want to work. I still want to be active at 90. And he just could not wrap his head around the fact that he was forced to retire because of his physical health. He's just so upset about that. But we were able to help him and to come to terms with that.
Well, that's awesome. I mean, yeah, because anytime that we're having to take something away from ourselves or feel like we're getting something taken away, it's got to have an impact.
Mm-hmm.
So, Tina, I just did put your nurse thing up on our Facebook page. That's what I was planning to do. So, that's why I wanted to get it, because as soon as this chat went away, I might not be able to grab it. So, but anyway, I wanted to get it out there. So, well, guys, this is, I think this is really important stuff. I mean, I think that, we're not going to solve the problems here today, but I want to get people aware of the problems and aware of the resources they can go, Michael, I loved what you just said there. That to me is something that, and you may not be the only ones that do it, but it's a great resource. The idea of trying to get in front of it, to me is huge, so, because I think it's got to be easier to make corrections before the crash and then having to deal with the aftermath and trying to put pieces back together, so I mean, you guys are there for that. Will you please post the resources, please? I jumped on a bit late. We have someone asked for something. What we're going to do is this video will be on Life's CoPilot. It'll be on our website. It'll be on our Facebook page. I'll give a copy to each one of you guys in case you want to use it in any way, shape, or form. And then we also, so those are two places you can get it, get the access to this. And then I just posted your, I mean, literally just now posted your resource of the nurses. What do you want to explain that again? What?
It's a spiritual renewal day for nurses. Now, again, it's spiritual, not religious, and I do want to emphasize that. Although we do have some religious text in it, but it's about being resilient and refreshing yourself, really renewing yourself so that you can go out and become a better nurse. And a lot of times nurses, we take everything on for everyone else. We take care of everyone else, but we forget to take care of ourselves. So we'll talk about that and some self-care. And we'll be including some of that when you sign up. It's free to attend, so anybody can come. It's free. It's on Zoom. It's online. You'll get the workbook and everything else that goes along with it. So this was my way of giving back for Nurses Week. And I did this last year and it was very successful. People enjoyed it. So I wanted to do this again.
Well, I appreciate that. I want to make sure they get people aware of it. On that topic, I was going to say, I had a friend and mentor decades ago who really changed my life on how to do things. I was finding myself burn out because I was coaching a lot of people and they were wearing me out. Okay. I mean, it was like, you're constantly pouring into them. And if you're not careful about pouring back into yourself, it can, and pastors have huge burnout because of that. And this particular guy, what his business was per se, is he was a pastor for pastors. He was always there to kind of guide them through all the stuff that they were carrying on their shoulders. But and he used an analogy that I absolutely loved. And that was, you can't load an empty wagon from an empty wagon. Okay. It's an old farm thing, but if you're not putting stuff into you have nothing to put into someone else. So, which sounds to me like what your upcoming event's all about. So guys, thank you so much. I'm going to do a real quick screen share here just to show you what's coming up. This was phenomenal. I was thrilled. So this was us today. Just kind of give you about Life's CoPilot. You can come in here and get information all the time. We've got, resources here. There's blogs written by people like our panel today. We have terminology, so you can go in there and find out what an ADL is. If somebody you start using those terminologies and these acronyms. We have a video library where this particular video will be probably within 24 hours or so. And then we have, and then all these past videos that are in here. We do 2 of these a month. We have upcoming events coming up. There's this ongoing one with Alzheimer's Association. This was us today. On the 24th this month at 6 p.m., we're doing a, again, hearing and speech month. We're doing a panel with hearing specialists and speech specialists. Then we're doing one on hospice in June. We're doing, which no one understands what that is unless they're in the industry. Indispensable resources for senior guide. This is kind of an overview of a bunch of stuff that's out there. We've got some good stuff coming up, and you can always find our partners that are here, learn more. If you want to contact us, here's how you can contact us. And there's just other things you can do there. So we are a free resource for the seniors and their family, and we just want to be able to put stuff here for people to be able to get access to these brains like we have here today, so we can get people the care they need. So anybody have anything left you want to say before we get out of here? Anyone?
Just thank you so much for the opportunity. Really appreciate it. It was great to meet my colleagues.
Well, thank you for coming. Thank you all. I really appreciate it, guys. I'll get you a copy of this shortly. Do you want to say something, Michael?
Yeah, I was going to say, echo that. So thank you, and it was nice to meet everyone. So,
all right, you guys. Well, Heather, Michael, Kimball, Tina, thank you so much for being here, and we will see you soon. Take care. Bye-bye.